name is Cynthia Chauvin. I'm very excited to introduce our next speaker today. I'm the director of the local CASA program here, and I feel quite certain that we've been very fortunate to have the opportunity to have a great group of professionals with us today talking about some pretty advanced topics in the work that we do every day. With that being said, I'd like to introduce Dr. Ken Roy. Dr. Roy is a fellow of the American Society of Addiction Medicine, a member and a distinguished fellow of the American Psychiatric Association, and an associate clinical professor of psychiatry at Tulane Medical School. He is the medical director of Addiction Recovery Resources Incorporated and the dual diagnosis unit of River Oaks Hospital, and works full-time in the private practice of psychiatry and addiction medicine. He'll now talk to us about addiction and how the role it plays with the families and children that we work with.
Anyway, my name is Ken Roy. I work in addiction medicine. I've been working in addiction medicine since 1985 full-time. Went back to training in psychiatry in 1992. And so now my psychiatric education adds to how well I treat people for addiction, but the treatment for addiction, the addiction part, has not really changed much. What I hope to do this evening or this afternoon is to challenge some long and possibly dearly held beliefs about addiction and about the place of addiction in the house of medicine and in the spectrum of medical conditions and disorders that people can have that produce pathology, that produce morbidity, which is not only physical health problems, but social problems and family problems and behavior problems. The first thing I want to do is I want to make a clear distinction between substance abuse and addiction. They are not the same thing. Substance abuse is ubiquitous. 80% of us in this room have abused substances, at least statistically, okay? When it's a problem, it's a social problem, a legal problem, and an economic problem. It is not a medical problem unless the abuse causes injury. The criteria for substance abuse is using alcohol or drugs in such a way that it causes problems in role obligations or danger to physical injury, recurrent legal problems, or social or interpersonal problems. Almost 50% of people 21 years old abuse alcohol. Okay? So substance abuse is something that's all around us. In fact, we don't even mind it. We like it. That's why we have Mardi Gras, is to abuse substances. It's a rite of passage. Everybody does it. People who have the predisposition for addiction don't stop doing it, and that's the difference. Something interesting is, we talk a lot about the problem of binge drinking and drug use among college students, but actually the rate in college students is not any higher than the rate across the spectrum of society. The treatment of substance abuse is primarily a social, criminal justice, and government issue. It has to do with the major advances that we've made in proposing and espousing prevention strategies. Prevention does a lot more to deal with substance abuse than it does to deal with substance dependence or addiction. The individual response that we should have to the abuse of substances by somebody else is that we don't excuse it.
You know, it's not okay to puke on my back seat. I don't care whether you're drunk or not. Okay? And we don't remove consequences. If you get a DWI and you have to go to jail, well, get yourself out. Okay? That's how you deal with substance abuse. Most people discontinue substance abuse unless they develop substance dependence. And every place you see this substance dependence, write addiction. Okay? I missed it on that slide, but addiction, it's going to be the new word. It's in our new manual that's coming out in a couple of years. We're changing the name from dependence to addiction because dependence is just a semantic basket case. And we don't know what we're talking about when we use that word. Addiction is very different. Addiction is a medical disease. It's a disease like high blood pressure or diabetes that happens in people who don't choose to have it. It is not a sought state. People don't wake up one day and say, I think I want to be a drug addict when I grow up. Okay? I talk to people in treatment all day, every day. That's what I do. And I've yet to meet somebody who decided when they were at that stage in life, you know, when you start growing hair and smelling bad and noticing people to fall in love with. I've never met anybody who said they remember sitting at the kitchen table at that time in life saying, when I grow up, I want to be an alcoholic. Okay? It is not a desired state. It is not a sought state. And in fact, the behavior of people that later on develop addiction and the behavior of people that don't develop addiction in high school and college is indistinguishable. Addiction has recognizable symptoms. We know how to make the diagnosis. It has a predictable course and it has a common cause. What causes addiction in one person is the same thing as what causes addiction in the next person. Now, the criteria for addiction are very well known. If you have access to a DSM-4, you can look it up or you can read it in your handouts. But it's basically using drugs or alcohol in such a way that causes problems in one or more of the major areas of life that you don't stop doing. Okay? There are 7 criteria for that diagnosis, and if you have 3 of those criteria, not necessarily at the same time, at any time during a 1-year period, then you have the diagnosis. And that's been pretty reproducible. There, like everything else in medicine, there are some people that seem to meet those criteria that really don't have addiction, but just about everybody that has 3 or more of these criteria at any time during a 1-year period has addiction. What I use when I talk to people, because I can't remember all of those criteria, is compulsion, loss of control, and continued use in the face of adverse consequences. Okay, compulsion is trying to quit and not being able to. You know, I have never met a normal person that has tried to quit drinking. Not once. Okay? Normal people just quit. Or they slow down, or they do whatever it is that they want to do about their relationship with alcohol or drugs. It's only people with addiction that try, sometimes over and over and over again without success, to quit using or quit drinking. Loss of control is the inability to reliably predict the amount of consumption or the behavior once consumption starts. Normal people can say, I'm going to stop at Joe's and have 2 drinks and get home at 5:30, and they stop at Joe's and have 2 drinks and get home at 5:30. People with addiction can say, I'm going to stop at Joe's and have 2 drinks and get home at 5:30, and sometimes they can do that. And sometimes they stop at Joe's and they have 2 drinks and they have 2 drinks and they have 2 drinks and they have 2 more drinks and they have 2 drinks after that, and they get home at 5:30 the next morning or 5:30 the next week. That's loss of control. People with addiction have that. Normal people don't do things like that. And continued use in the face of adverse consequences is pretty self-explanatory. Now, most studies show that the incidence of addiction is somewhere between 5 and 15%. Depending on the study, depending on the criteria used for making the diagnosis, depending on the mechanism of the study, they always come in about 5 to 15%. There is a lot of crossover, and this is increasing. The trend to using more than one drug of abuse or more than one substance that people become addicted to is increasing over time, so that there's a high percentage of people who are have the disease of addiction, which is different from being addicted to alcohol, have the disease of addiction related to alcohol and have the disease of addiction related to pain pills or benzodiazepines, nerve pills. That is increasing over time. And more recently, a lot of this is prescription drug use, misuse, originating out of a fashion swing in medicine, kind of like bell bottoms, towards the liberal prescription of opiates for chronic stable pain of musculoskeletal origin. We didn't used to do that. And now there's all these pain clinics, or there have been. I think we're on the downside of that fashion swing, but we still have a lot of prescription drug abuse. In Louisiana and in most other states, there is a difference between rural and urban populations in terms of statistically what drugs you're likely to see more often. In an individual, it doesn't matter. Individuals that live in the city are speed freaks. Individuals that live in the country are heroin addicts. But statistically, you have more methamphetamine and more marijuana possibly in rural areas, and in urban areas you have more heroin and more cocaine. So what is the worst drug? And in my humble opinion, that is not a very helpful way to think. Okay? They're all worse drugs. Alcohol can be just as bad as any other drug. However, there is one component that does have something to do with what we do when we get involved in helping people with addiction. And that is that the more illegal the drug is, and by that I mean not the penalties necessarily when they get to court, but how many criminals are involved in the distribution chain, and how many crimes you have to commit to get the drug, and how many criminals you have to associate to be in that lifestyle. Those things all contribute to criteria that would indicate how long and how intense treatment should be. The course of addiction is that it's progressive. It never goes away. The idea of being recovered is no more valid than the idea of being recovered from high blood pressure or being recovered from diabetes. You don't recover from addiction, you are in a recovery process. So we don't talk about people being cured. That's an old moral model idea where people used to think that the reason someone had addiction is because they decided to, they wanted to, and they were bad and evil because they did that. And we could send them someplace pretty by a lake and they would get cured. And both of those things are not true. Addiction often is progressive. The long-term recovery rate still isn't great. It's as good as it is with asthma. It's as good as it is with some forms of high blood pressure, but it still isn't great, and it can be a lot better. It often is associated with why people die. It's a disease of relationships. You know, if all somebody did was put something in them that changed their brain, and they sat like a lump in a corner and didn't talk to anybody, it would not be a very big deal. But addiction is a disease of relationships. And it causes disturbances in the relationship with self, and then with those with whom we should be intimate, and then in ever-widening circles of people. And all of those disturbances and all of those relationships are based on the primary universal symptom of addiction, which is denial. And denial is subconscious and the elaborate, intelligent, and insidious subconscious set of ideas, beliefs, and behaviors that allow somebody to use an addicting substance again and again and again, when each time they do that, it hurts them and the people they love more. By the time somebody comes in front of you, in whatever relationship, and the use of substance is a part of their coming in front of you, 99.99999% of those people will not have substance abuse, they will have addiction. So that the people you see that abuse substances, and all of my patients abuse substances, the people that you see that abuse substances will be doing that because they have the disease of addiction. Addiction is a genetic disorder. I told you that if something is a disease, it has an identifiable set of symptoms, it has a predictable course, and it has a common cause. And the common cause of addiction is that it's a genetic disorder, and people that have it were born with it. And having been born with a genetic predisposition to addiction, if they drink alcohol or use drugs past a certain threshold, then they get it. And they've not much had a choice in the matter. Now, that's a pretty strange thing to say, isn't it? It's a lot different from our long-held social, moral beliefs about addiction. Okay? Yes, sir.
Do you mind a question? Does that imply that they get it from their parents?
If it's genetic, it does imply that. Yes, sir. Okay? So, how do I know that? Did I just make that up? Am I just some sort of proselytizer that wants to come around and make you guys think something that you didn't think before? Well, I can tell you that 9 out of 10 of every patient of every one of the patients that I see has a first-degree relative with alcoholism. And back when I was doing family medicine, that wasn't true. When I saw people with high blood pressure or rheumatoid arthritis or cancer, they didn't have, 90% of them didn't have families with alcoholism. And in my practice, the 10% who don't have a first-degree relative with alcoholism either come from families that don't drink for reasons of religion or poverty or immigration, or else they come from families that keep secrets. And they don't find out until later in their recovery about the addiction. So people that do what I do for a living have known for a long time that this is a disease that runs in families, but there are a lot of things that run in families that have behavioral and psychological characteristics that are not genetic. Religion runs in families. That's not genetic. Politics runs in families, at least in Louisiana. That's not genetic. In order to prove that something about you that has behavioral and psychological characteristics is genetic, as opposed to being predicted by who raised you and how they did that, you have to do research. You have to do research that removes the influence of who raised you and how they did that from whether or not you developed that condition you're doing research on. And what you call what happened to you growing up is parenting. And doing research on people in a way that removes the influence of parenting would seem difficult, because most people are raised by their parents. You can do that in very large studies with very large numbers of family research. But there are a couple of very elegant ways to do that kind of research. One is a twin study. When you do a twin study, you compare the concordance of a disease you're looking at in identical twins and compare that with the concordance of the same disease in same-sex fraternal twins. The idea of a twin study is that twins are born at the same time, they have the same parents, they live in the same place, they're the same age, and pretty much the same thing happens to them. Identical twins have the same exact genes and chromosomes. Fraternal twins are no more closely related than any two brothers or any two sisters. So if there's a clear difference in the concordance of the disease you're looking at in identical twins versus fraternal twins, the reason for that difference is genetic. When you do a twin study on addiction, what you find is that in identical twins, if one twin's addicted, the other one is, just about every time. But in same-sex fraternal twins, if one twin's addicted, the other one is 25% of the time. And that's the same as you find in any two brothers or any two sisters. Now that's real clear, it's real clean, it's simple, it proves it to me. I like that, but scientists like big numbers. So how would you do research on a large number of people for the development of a condition with behavioral and psychological characteristics who haven't been influenced by their parents to develop that condition? You could do research on a large number of people who have never met their parents. And that's called an adoption study. When you do an adoption study, it's pretty easy to round up 1,000 people who were adopted at birth and have not significantly been impacted by their birth parents. And if you study those people that were adopted for addiction, and you study the people that raised them for addiction, you find that there's no correlation. But if you go back and find the biological parents of these adopted people, what you find is that if the biological parents had addictive disease, then their offspring develop addictive disease at a rate 4 times higher than the rate of development of addictive disease in the offspring of non-addicted biological parents. Now, this combination of twin studies and adoption studies prove beyond a shadow of a doubt that this is a genetic disorder, and there wasn't just one twin study done one time or one adoption study done one time. I can attest that in the 1980s, when this information first hit the medical literature, almost everybody said, baloney, that can't possibly be true, and these studies were replicated. And now there are literally hundreds of twin studies and hundreds of adoption studies, every single one of which has identified the genetic contribution to addictive disease, and there has not been one twin study or one adoption study which has claimed its results to have disproven the genetic contribution to addictive disease. So that's what proves it to me as a scientist. We also have one disease. We do not have alcoholism, marijuanaism, cocaineism, heroinism, and Valiumism. We have one disease. We call it addictive disorder or chemical dependency. How do I know that? Well, when people come in for treatment with me, sometimes I can tell what drug they've been addicted to by how they look coming in the door. But once they get into treatment and they've been there for a week, I can't tell them apart. I would have an easier time figuring out where somebody went to high school than what their drug of choice was, once they've been in treatment for more than a week. When I get their family history, no matter what drug got them there, it's always the same. Oh yeah, they're alcoholic. And when they get to group, they all say the same thing, starting with denial. So we have a disease that looks the same, acts the same, and has the same family history. It probably is the same. And in fact, there's been lots of research that has identified the genetic contribution to addictive disease. The disease lives in the primitive instinctual survival brain. Let me ask you, how many of you guys are interested in cannibalism? Like, would you like to eat somebody? Didn't figure you would. Okay? But you know what? If we were stranded in a plane crash in the Andes Mountains and we had all the snow we wanted to use for water and no food, within 3 weeks we would eat each other. Okay? And that we would do that lives in our primitive instinctual survival brain. It's that part of our brain that says we have to do what we need to do to stay alive. And addiction hijacks the instinctual brain so that the person with addiction literally believes at a subconscious level and behaves as if they don't get what they are addicted to, they will die. We can look at them and say, no, that's not true. But that person's instinctual brain is hijacked, and they literally believe that it's a matter of life or death that they continue to use. So why is all that important? Why is all those things I just told you important for us to know? Well, for one thing, addiction causes problems. Problems don't cause addiction. I could just as easily and rationally and probably more correctly argue to you that addiction causes poverty than I could that poverty causes addiction. It's a primary illness. It also helps to understand denial. Remember when I showed you the primitive instinctual survival brain and said that it gets hijacked? The way it gets hijacked is by developing that subconscious denial system, all the beliefs, all the behaviors, all the thoughts that are just as intelligent as the person that has them, that convince that person that somehow it's okay to keep doing what they've been doing. When addiction is understood to be a disease, then providers don't shame patients. Okay? I can tell you, as a now experienced psychiatrist, that nobody ever got well from this. Nobody ever got well from this. Okay? And a shaming therapist is an ineffective therapist. And the patients have a healthy target to work on. They can work on my addiction, not my badness, not my bad self. Abstinence is the only reasonable goal. When somebody's addicted, once they cross that threshold, they cannot use again successfully. The idea that an alcoholic can learn how to have 2 drinks, or a heroin addict can learn how to chip every once or twice a month, or an alcoholic can smoke weed, is just baloney. It does not work. It always predicts relapse. And that relapse will always come. Maybe in a day, maybe in a week, or maybe in 3 months. But it will always come.
So if your drug of choice was heroin and you went through recovery,
Right.
you really can't drink alcohol because
Right.
the addictive impulse is still there?
Right. What happens is that in a part of the primitive instinctual survival brain, the use of heroin feels like, or the use of alcohol feels like the use of heroin. The withdrawal from alcohol or hangover feels like withdrawal from heroin, and the urge to use heroin is sometimes overwhelmingly strong, and relapse is predicted. When somebody has addiction, denial is the primary and universal symptom of the disease, and the identification with other people that have that same denial is possible. Oh yeah, I got what you got. And you may know this from other things that you've done, but when people have shared stressful experiences, they can bond around those experiences. And that's why mutual help processes work and are helpful. And it also, if you understand the idea that addiction is a disease, you can't cure it. You can't send somebody to a pretty place by a lake or to Red River and have them come back cured. It ain't gonna happen. You have to continue a treatment process that starts on the first day and lasts for at least a year, preferably 2, with monitoring after that. Recovered versus recovering, I've kind of covered this. It never goes away, and casual use is not compatible with recovery. Casual users will always relapse. The casual use of less addicting behavior or less addicting drugs, like a heroin addict using marijuana, will predict relapse. Okay, it's not something that we should tacitly condone. And when addiction is part of the reason for separation of families, abstinence should be required. Now, this is my challenge to you. I told you when I stood up that I hope to challenge some long-held beliefs. You guys have tremendous power, okay? You work in a system that has access to grant funding and federal support and state support that can change the system that we have. And I would encourage you to think through the filter of this presentation and change that system, because what we have now doesn't work. But we can design systems that do work. And I'll talk about that in a minute. Now, the kinds of drugs that are abused fall in only 4 classes. It's not rocket science. It's alcohol and other sedative hypnotics, cocaine and other stimulants, heroin and other opioids, and hallucinogens. Actually, the most significant inhabitant of hallucinogens is marijuana. I mean, the other hallucinogens are sometimes troublesome, but don't often produce addictive disease. The predictors of recovery. How can, if you're going to design a system that's going to predict a certain number of people will get well, how would you design that system? Well, all the research shows that there's one predictor of success in treatment, and that's length of time in treatment. If you can engage somebody in treatment and maintain them in that process for up to a year, you get a very high recovery rate. If you can do that for 2 years, you get an extremely high recovery rate as compared to the recovery or relapse rate for asthma, high blood pressure, other chronic medical diseases. Okay? So the length of time in treatment. The American Society of Addiction Medicine has an 1.25 inch thick book that has the criteria that help determine what level of treatment is required for people that need treatment for addiction. Unfortunately, we live in a situation where that level of care is not always available. My challenge is to say, okay, this is where we are now, let's change it. Let's make it better. And treatment should always be individualized. There's no cookie cutter treatment process that works for everybody. A key example is if you take 100 opiate addicts or heroin addicts even, some of them will do much better in their life if they go to methadone maintenance programs, although I have to tell you I hate methadone maintenance programs. Some of them will do better in their life if they take buprenorphine or Suboxone prescribed in a doctor's office, and some of them will do better in life if they don't take any opiates at all. They will all do better in life if they go to treatment for addiction, which is different from anything that I just said. Okay. The follow-up, the long-term follow-up is the key to recovery treatment. Now, let me just say a few words about professional health programs, because as part of my challenge, sometimes it's easier to do things on both ends of the social spectrum that eventually and later on help the middle class than it is to start with the middle class, just because the thinking is not right. We all have this long-held belief system about what we think addiction is. But professional health programs are programs that interact with licensing boards for physicians, pharmacists, nurses, other professionals. And what happens is when those professionals get sick with addiction, they're is a arm of the board or an arm of the medical society with a relationship with the board that insists that those professionals get a kind of treatment that isn't ordinarily available to other people. And the recovery rate from that kind of treatment, as measured by abstinence and recovery, two different things, at 5 years is better than 90%. You hear that number? Better than 90%. And there's no reason that it couldn't happen for any group of people. These are programs that start with treatment that's long enough, the primary treatment's long enough. Then there's a monitoring contract, usually for 5 years, with documented continuing care attendance and documented 12-step meeting attendance, and urine drug testing. Urine drug testing is key to these programs and can often identify people in the very first stages of relapse and get them back into the treatment process. The current system that we have, for the most part, is based on moral ideas about addiction. You know, you literally have to get down on your knees and beg to get treatment. Now, if you think that the primary and universal symptom of the disease is denial, and then you're going to make people beg to get treatment for it, that does not connect, okay? What we have don't work. Patients are shunned for relapse. That is absolute, pure moral model ideology. It's a chronic relapsing disease. It's like getting mad at somebody because their blood pressure went up. We are in the beginning of a brave new world. It's now the law. Each of you that works for an employer, except the state, with more than 50 employees, if you have any coverage for the treatment of addiction, you have as many dollars for the treatment of addiction as you have dollars to treat heart trouble or stomach trouble or cancer. Okay? Parity is the law of the land as of January 1st. If your policy has been renewed since October 4th, 2009, and you work for an employer with more than 50 employees and you have any coverage for mental health, you have as many dollars to spend on treatment as you had to spend on treatment for anything else. All of the healthcare reform efforts, and we will have healthcare reform, all of the healthcare reform efforts identify parity or identify addiction as a disease and require parity in resources to treat addiction. So we're entering a brave new world. We will have resources that we don't have today. But I also suggest in interim that you guys, with the power you have, look for grant funding through the courts or through voluntary or nonprofit associations to improve the system. For instance, there are not enough reasonably available treatment facilities that accept women with dependent children. I can't tell you how many times I have had women not access the appropriate level of care because they had child care responsibilities. And the women that did access the appropriate level of care essentially abandoned their kids. So it's a horrible situation. Oh, and the other thing is you can design a physician's health program-like system using reunification as the carrot and sometimes incarceration as the stick and get the same damn results. Coerced treatment or involuntary treatment is exactly as successful as voluntary treatment in any study of matched controls. Urine drug testing is the best way to document recovery. It requires the development by somebody who knows what they're doing. You can't just tell people to go in there and collect urine because they'll have a bag of it on them. Okay, it has to be collected in a certain way. There are acceptable techniques that don't require direct observation, but they are involved. The panel of drugs that you test people for is important because, let me tell you, somebody with addiction in the 21st century is a lot better psychopharmacologist than you are. Okay? And randomized collections are necessary. Now let me go through dual diagnosis. The dual diagnosis concept is the opposite of the old idea that using as a coping mechanism for psychological lesions, and this is the idea that's been common in psychiatric programs, and the goals are to get from a place where you need to use to get to a place where you don't need to use, and it certainly stresses the treatment, the diagnosis of psychopathology, but the psychopathology is seen as the etiology, and that's not true. Substance dependence or addiction is its own disease. Self-medication is an antiquated model. However, use may cause psychiatric symptoms, and these may or may not be temporary. Substance dependence always requires its own independent primary treatment. Psychiatric illnesses are always primary. From the place where I started in my treatment of addiction, we would say about people that were bipolar, oh, he's just a crazy alcoholic. But that was an error I made back then and missed the diagnosis of bipolar disorder. So addict behavior is an antiquated model. And sometimes people with psychiatric illnesses use in a way that turns out to be abuse, although it looks like addiction at the time that they're using. There are some gray areas, and like I mentioned, there are some people that, when it all comes out in the wash, we find out that they really did have abuse and not addiction. Now, denial is the universal symptom of addiction, but do y'all remember that time in life after age 13, before you got to 20, how painful it was? Okay? Remember going through these awful times, nobody loves me, and I'm angry and I don't know what to do about it, and you figured out a way, right? And by the time you were 20, you got pretty much a lot of that stuff nailed down. By the time you were 25, you're a fairly competent individual. People with addiction, that doesn't happen. If somebody's 14 years old and they have addictive disease and they're using drugs, they say, I don't like the way I feel, so I think I'll change it. And they develop an arrest of maturity that starts at the time of pathological use. So that people may be 30 years old in longevity, but be competent emotionally at the age of 14. And one of the reasons those of us with addiction like each other so well is developmental emotional arrest. Let me go through these kind of fast. Anxiety disorders, affective disorders. Somatoform disorders are uniquely intertwined with denial, because somatoform disorders are the belief that's generated by long-term substance abuse that if something's wrong with me, I can put something in me that'll fix that. And that what's wrong with me can be fixed by a pill, a substance, or the action of somebody else. But there's nothing I can do to fix that. Pain disorders are a lot the same thing. Psychotic mental illness is not the same thing as serious mental illness. All of the mental illness is serious. schizophrenia, schizoaffective disorder are all examples. Now, personality disorders are an enduring pattern of abnormal inner experience, manifested by mood instability, errors of cognition, poor impulse control, and are problematic interpersonal functioning. And there's 3 clusters of them. 28% of alcohol use disorders patients have at least one personality disorder, and 47 or 50% of all people with drug addiction have at least one personality disorder. And 15% of people with personality disorders have an alcohol use disorder, and 7% of people with personality disorders have a drug use disorder. Symptoms of personality disorders do not change rapidly, they change slowly over time, and fortunately for those people with addiction, 12-step recovery is wonderful treatment for personality disorder. When somebody comes to me for an assessment, it's a different relationship than a physician-patient relationship. See, if somebody comes to me and they walk in the door, make an appointment and say, "Doctor, I have these symptoms, can you help me?" Then I am the physician, they're the patient, we have a physician-patient relationship. My goal is to be of service to that person. If somebody is sent to me by you, then you're the patient. And the person is sitting in front of me is my responsibility to evaluate. Now, if you haven't practiced medicine or you don't have patients or clients, that may be a little bit of something to wrap your head around, but it's an absolutely radical change in the relationship. Even though the chairs are the same, they sit in the same place, I say some of the same things, it's a radically different relationship. The subject may come from a licensing board, an attorney, you guys. The patient is you guys. The person sitting in front of me is an evaluee. It's inherently adversarial. They don't want me to know what's wrong with them, and my job is to figure out what it is that's wrong with them. A report is always generated, and the recommendations often demand time and resources and restrictions. We do those things at Addiction Recovery Resources all the time. I would like to introduce and point out Lisa Carroll, who works with me at Addiction Recovery Resources, and as I say, we work in the private sector and do these things as well as primary treatment. And one more slide. People with addiction almost never stop using or drinking because of sanctions alone. You can't incarcerate somebody often enough or hard enough to make them stop using. It just doesn't work. There is an opportunity to balance treatment, support, and sanctions. And that's exactly what happens in professional health programs. It's a balance of treatment, support, and sanctions. And how do you tell when to reunify? It's individual. It requires a negative urine drug screen and compliance with treatment recommendations as recommended by a competent treatment professional. Okay?
That was it?